Good afternoon or evening, depending on where you are in the world. Welcome. I'm Kate Folb. I'm Director of Hollywood Health and Society, which is a program of the University of Southern California Annenberg School for Communication and Journalism's Norman Lear Center. At Hollywood Health and Society and the Lear Center, we know that stories matter. Humans, all of us, like to tell stories. We've done it since the beginning of time. We're entertained by them and we learn from them. Stories can and have changed the world, which is why we feel it's important that when covering topics like health, science, and safety, that our stories be accurate. Because when it comes to health, people take what you present in your stories often as the truth. So Hollywood Health and Society is a free resource to the entertainment industry on all topics around health and safety and security. If you're interested in writing about diabetes, about HIV, heart disease, addiction, reproductive or mental health, and of course, today's topic, breast cancer, among many, many others, we can connect you with information and experts like those you're going to hear from today to help ensure your storylines are as accurate as possible. We understand your timelines and we understand your challenges as TV writers or screenwriters, but we're ready to help. And did I mention it's free? So please give us a shout. We're at the ready. Operators are standing by to take your calls and your emails and help you make the health storylines that you're writing about as accurate as possible. Two recent areas of focus, which I'm sure most of you are well aware, are COVID-19, which we have done a number of these kinds of panels on, and you can find them on our website if you're interested. And the other area of interest is what we're calling the social determinants of health, or a culture of health. Things like racism, immigration, and other socioeconomic factors that can affect the health and well-being of many and need to be covered and explored more deeply. Young Black women face a higher risk of breast cancer and are often diagnosed much later than their white counterparts. Today, we're going to discuss how racism, bias, and health inequities can affect a young Black woman's breast cancer journey in systemic as well as personal ways, and explore how TV storylines can raise awareness about this issue. Now, we'll be putting the bios of all our panelists in the chat so we can get right into the discussion. And although the majority of our panelists are doctors or healthcare providers of some sort, we have opted to call everyone by their first name. Also, we're going to be taking questions from the audience in the last 20 minutes or so, but you're welcome to put your questions in the Q&A function whenever they occur to you, and we'll try to get to as many as possible at the end of the discussion. Okay, so our moderator tonight is the co-chair of the Hollywood Health and Society Advisory Board. She's an executive producer of Grey's Anatomy, and she's also an MD herself, as well as a mother of 3 adorable children. And if we're lucky, maybe somebody will poke their head in. Please welcome ZOANNE CLACK.
I don't know that lucky is the word that you're looking for there. Inevitable might be the word. Hello, everyone. Thank you for joining us for this really, really important talk. As Kate mentioned, I do work on Grey's Anatomy, and I've been there for most of my life, 17 seasons. But for those of you who have seen Grey's, you might know that the Grey's landscape is one of kind of an aspirational hospital with doctors who would never underdiagnose or treat patients, regardless of race, creed, color, or insurance status. So it's often been hard to address some of these issues, and it takes a lot of creativity to tell these kinds of stories. But this season, we've been blessed with the gift of COVID, as it were, and that has allowed us to use the societal ills that COVID has uncovered to get a bit into the inequities that have always existed for marginalized communities. So that has been the blessing coming out of the curse. Okay. Our first guest, Tamika Fairley, is well versed in these inequities. So let's just get started because we have a lot of ground to cover and a lot of really interesting and informed people to talk to. And let's welcome her to our chat. Tamika, hi.
Hi, how are you?
I am, making it
Like all the rest of
through
us.
the quarantine. And we just want to get right into it.
Sure.
Can you tell us about some of the unique barriers that Black women have to face in the healthcare system?
Sure. So I certainly we've seen or heard more of this, you're right, over the last year or so as COVID has emerged. But this is actually an older issue and something that Black women have been facing for some time. And one of the biggest areas is really about access to healthcare. And so access to healthcare could look like a few things. It could look like being able to afford care, having a hospital or a clinic in your area where you can access certain kinds of care, or even having just a basic, primary care provider. So there's some of those system level issues or environmental level issues that are challenging. But then you see other things like, community-based issues, not being able to have access to healthy food. So you see those kinds of things. When we move into the healthcare system and access to healthcare specifically, one of the big things that we hear Black women talk about a lot is being seen by providers, one, that don't look like them, or seen by providers who don't hear them or really see them because they look, sound, or whatever that perceived difference is. And what that translates to a lot of times is not being heard, right? Possibly by your provider when you say something's wrong. I remember watching this HBO special about Serena Williams. And if you remember, as she was having her first child, she had an issue and she was having a complication. And it took them a long time for her provider to actually engage when she was saying she knew what was going on. And so that is a really, big issue for African-American women. But then there are other pieces where African-American women may not be seen as the same as their other counterparts. So things like African-American women can tolerate more pain. African-American women have thicker skin. They're stronger. So we don't have to give them the amount of pain medication that they need because they possibly, are stronger and can take it. So we see those kinds of issues showing up. But I put them all under issues of access to care, because when you can't trust your provider, doctor, nurse, whomever, you don't really have access, right, to the kind of care that you need. If you can't get health insurance or actually live somewhere where you can get appropriate care, it's the same. So it's a really big issue. It's been going on for a long time, and we're hoping to really do some more work to address it and kind of add to the work that's being done already.
Yeah, what I heard you saying, just in a nutshell, actually not in a nutshell, I'm not going to put all of what you said in a nutshell, but one of the things I think you hit on, which was important, is the Serena thing and how this transcends the socioeconomic status. Like it goes far beyond, how much money you have or whatever, whatever that's concerning. And one of the other things that what you said brought up for me was the huge increased risk for maternal mortality in Black women as opposed to other races and people of color. And just like the preconceived notions that providers can come in with, because I remember there used to be a medical book, which I think has just recently been changed, about how all the different cultures perceive pain.
Mm-hmm.
And one of them, this was taught to medical students. And in keeping in line with that, how have you seen that racism or bias itself can affect patient and healthcare and the relationship between the two?
Yeah. Well, even the example that you were talking about with regards to pain, there was a study that came out a few years ago about cancer survivors that said that, African American women who are cancer survivors who often experience a tremendous amount of pain as a result of their treatment, whether it was surgery or radiation or what have you. And it showed that those women were not being given the appropriate amount of pain medicine, were not being given the same pain medicine as their white counterparts, and so that kind of pain can lead to emotional and mental health issues, right? Untreated pain over long-term periods may lead to additional stress. And we know that stress is this huge, issue when you start to think about other chronic conditions. And so racism and those, but especially racism and stress are so closely connected, when we start to think about those things. And we do believe that that's why we see things like more chronic conditions in African American communities, particularly among African American women. Racism-induced stress, the experience of racism, the perception of racism just has a tremendous impact on women's health.
Definitely. There's this concept called weathering. Have you heard of that?
Mm-hmm. I haven't heard of this one.
It's basically what you're saying is that,
Okay.
All the extra stress that Black women have to endure, along with discrimination and racism in their everyday lives, can affect their actual physical health.
Yeah.
I was trying to get we're actually going to address that in one of our episodes coming up. Of course, that I wrote because I feel that pressure.
Okay.
But yeah, it just reminded me exactly what the theory is. And basically you're just saying what they've studied out there in a different kind of way. It's just a fact, basically. Yeah. It's like people are studying it, but we live it and it's just a fact. Go ahead.
No, I was going to say it's really what's really great, and I guess it's the blessing out of this. One of those other blessings out of COVID is that in public health, which is the perspective that I'm coming from, that there's now a true acknowledgement across the community that racism is a public health issue, and that it's affecting people of color, in these tremendous ways. And so now when we take a look at things, and now when we try to address them, we're starting to consider like what role racism is playing, whether it's structurally or personally in terms of people's experience. So, I'm excited to see that happen. It's been a long time coming.
For sure. Like racism as a public health crisis, yes. I mean, it's always been a crisis. So to make it that acute seems unnecessary, but also necessary. Yeah. At the same time, because other people are just now realizing it, I think.
That's right.
So from your perspective, what are the most pressing issues facing young Black women today in relation to breast cancer risk?
Oh, yeah. So what we know from just the numbers is that African American women are more likely to be diagnosed with breast cancer before the age of 45. And that's been a large issue in the past because screening recommendations for breast cancer have not started in many cases till the age of 50. And so you were having all of these young African American women, women under 50 who were showing up with these, what were considered early onset breast cancer. But we know that even once they're diagnosed, because there's no screening, they may be diagnosed later. We know that they may have a more aggressive disease. We know that it may be difficult to treat. It may be something called a triple negative breast cancer, which is, I think people hear about that one a lot, which only responds to chemotherapy. So, which is usually a very aggressive treatment. And that they tend to progress to metastatic breast cancer or tend to die more often than white women who may have been diagnosed at similar stages. And so it's from my perspective, it's a crisis in that part of the community to make sure that we're acknowledging what's happening. We're acknowledging the role that access to care has on this community and just all of those topics.
And what are the screening recommendations as of now?
Yes. So the screening recommendations right now, according to the task force, which is who CDC follows, is still the screening starts at the age of 50. But there's a lot of dialogue about talking you to your healthcare provider about that before that. There's a lot of discussion about starting to get screened at age 45 for Black women. And then when you look at places like the American Cancer Society, they are saying start getting screened at 40 and 45. So there's a range in there. And I don't know that it necessarily should be, but in terms of what we hear from clinicians, is there's this range in there as to when they start screening.
And when you say screening, do you mean just mammograms or? Yeah.
Yes.
Oh, okay.
So when I say screening, I mean that the initial screening that's recommended for women over 50 is mammogram. And then because there's nothing necessarily recommended for women, certainly under 40, and in some cases from the CDC perspective, under 50, there's nothing.
Huh. Did not know that.
Yeah.
I did know, however, that colon cancer,
Yes.
which is running rampant in the Black community, which our beloved Black Panther died of,
Yep.
I know that it's supposed to start at 50, but I know the public health recommendations have moved that down. But when I went to try to get one before I was 50, my insurance company was like, no.
Oh, wow.
So we had to like fight. And just because, I mean, I had a friend that died when she was 45, Black woman. And I have young kids, and I was like, no, I need to be screened now. So it is about kind of speaking up for yourself and trying to get these things done. And speaking of that, how do you feel that healthcare providers can empower young Black women to speak openly about their health concerns with their doctor and advocate for themselves?
Yeah. Wow, I think one of the big issues, of course, is trust. So not as to put it all on the healthcare provider. There's this part that we come to the table with, and where we really have to, in the instances that we can, go and see a healthcare provider that we trust or that we feel like we can trust. When you go see someone that you don't think you can trust, it really doesn't matter much about what they say, to really make you change that perception, right? I think you can do things to try to listen more, to not, be hasty, and certainly not make any preconceived notions, which in and of itself is easier said than done, because you have to know that you're doing that first. But I tell young women, or just people in general, you want to find a doctor, nurse practitioner, or whomever, that you trust and feel comfortable with seeing, if at all possible.
So again, what I hear you saying is more Black providers, or more people that look like yourself, is probably going to have that more of an area of trust, and also less of the preconceived notions of what they should or shouldn't be going through. So we just have to get a few more people of color physicians.
Yeah,
that's all. It's very simple.
It's less of the preconceived notions, or less of the perception of that, right? Because it's not that all healthcare providers are biased or are racist or what have you. That's certainly not the case, but perception is reality for a lot of people. So that's a challenge.
Perception is reality. There you go. Thank you so much, Tamika. It's so hard to not just call you Dr. Fairley, but I'm just going to go ahead and do that. I think we're going to try to move on now to Katrina, who is not Dr. Armstrong. She's Katrina, to talk a little bit more about just kind of the medical perspective of breast cancer and breast cancer in young women. And one thing that Tamika was saying is that even when they're diagnosed at the same point, that Black women tend to go on to progress to metastatic disease more often. And can you tell me a little bit about why that is, or do we know?
Yeah, so I'd say there's part of it we know, and there's part of it we really don't understand. I often think, and I should say this was quite a long time ago, that I became interested in this because of a patient who showed up just after I'd finished medical school and I'd first started practice, who presented actually with cancer that had spread. And, the reality was that I learned so much from her. She had worked in the hospital where I was a resident for her entire career. And she, even having worked there, I think to Tamika's point, was really not trusting the doctors in that hospital. And so went to a community clinic way outside of the hospital. And I'll never forget meeting her because I couldn't believe it when I actually felt a lump in her breast. I just finished medical school. I was completely shocked. And, it turned out when we did tests that we had found that it had spread even beyond that. And I still think of her, partly what I think about her, ZOANNE, is that she was so proud that she had saved all her life, even though she worked as a frontline worker, to buy her house. But her job at that time didn't give her the type of health insurance that covered her outpatient treatment and everything. So she only had a coverage when she retired for being in the hospital. And so before she ended up dying from her cancer, she actually lost her house. And it was like the one thing that she had saved for. And so I just carried her with me from all that time. And so I think her cancer, when her cancer spread, it's partly because the cancers are more aggressive in certain people. And the paradox of that is they're more aggressive because we haven't done the research that gets the right treatments for those types of cancers. So I think they're partly spread more quickly because they're a type of cancer that we have excluded Black women from most research studies. And then we don't have the treatments for a patient like mine who shows up with advanced cancer. I also think, back to your point about the weathering hypothesis, and I know somebody's asking ZOANNE about what that is. I think we do believe, in fact, we just did a study that shows that people who live with more stress, so what you're talking about, more racism, more discrimination, more economic stress, have different immune responses. So their body reacts differently to different types of disease. And those things we all believe can make disease spread more quickly.
That's really interesting because because of the fact that our human genome has been, we're 99.9% the same. So that's why I was so interested in why it would be worse in, like culturally. But that makes a lot of sense that the stress and that sort of thing can have a different effect on the body. And therefore, yeah, I was going to ask if there was like some social determinant of health, but I think that probably is it, or at least a piece of it. So thank you. That's really interesting. And yeah, somebody was asking about the weathering, and I think the medical term for it has been stress-related biological aging is what I think it's called.
And you know what the paradox is about that, ZOANNE, is that actually, if you look at that weathering, that it's really something that at a certain point, certain groups start doing better because they've lived through this incredible stress that society has put on them. And so this really is an issue for young people in particular. And I think we should try to remember that. It's really an adverse experience as people grow up.
Mhm.
So interesting. I'm just going to go back a little bit. I think we've covered a lot of ground except for the basics. Like, what is early onset breast cancer and what are the symptoms and risk factors that people should be looking for?
Right. Well, I think a lot of it really is about this idea that if we all live long enough, we're going to get some form of diseases, it turns out. I think that's probably not news to your audience here. I know we're all against aging, right? There's a whole way we should just be getting rid of aging. But the reality is what we all kind of want to do is to live long enough that we don't get diseases when we're young and that we can somehow pass away at a very comfortable old age. And so when you have early onset breast cancer, what that usually means is that women in their prime of their life, when they're managing, as you are, your children running around, when you're at the height of your career, are diagnosed with a disease that otherwise most people wouldn't get into their 70s or 80s. Not that we want them to have it in their 70s and 80s. But so I've had patients, I just had a patient come see me probably 6 months ago who had actually gone back to school. So she had raised, her children had gone to elementary school. She'd gotten them out of the house. She'd gone back to school and got her nursing degree, which was what she was really excited about. Came to see me, and it turns out that she did go for a mammogram back to the screening and was found to have a lump. And so that time before 40, before 45 is when we really think about it being early onset. And the importance of it really is because that is the prime of people's lives. They're managing their families, all of these different issues are going on. And so the complexity of managing treatment at that time, having to go through treatment, having to figure out radiation, having to tell your family, I sat with her as she tried to figure out how she was going to talk to her children about this. Sat with her to try to find, to Tamika's point, who was going to be a doctor she trusted, who was going to talk about the options with her. And so I think it's that early piece is really about the lives that people are living when they get diagnosed.
There's an interesting question in the Q&A that I think would be good for you. It says, what is the efficacy of manual breast exam versus mammogram? And aren't manual breast exams part of the regular appointments for pelvic exams?
Yeah, so this is a great question and has been a long-standing debate. I should probably let Tamika tell everybody what the CDC recommendations are here. But so it turns out that we, in general, I'm a primary care doc, so I see patients who come to see me with a variety of different complaints, as you know. And so for us, I think we do recommend that women do self-breast exams, and I do manual breast exams when somebody comes to see me. But so, and they've never actually been able to prove that that changes breast cancer outcomes. And in fact, the studies were mostly done actually in China. So honestly, it's hard to know how much that relates to young Black women who are facing all the issues here today. So my personal recommendation as a doctor is to continue to do self-examination and continue to see doctors who do examinations. But the public health community has had to be careful because it's hard to come out and say, do something if the studies haven't shown that it makes a difference.
Tamika, do you want to address that?
So what we do know about young African-American women who are diagnosed early, as Katrina was saying, is that a good proportion of them, 60 to 80% of them, find their own breast cancer, right? Mm-hmm. And so that is a significant number of people, going in, to say something's wrong, I have a lump, I have something, who are at an age where they may not have ever been screened. And so I think with that being said, I definitely defer to the young woman's healthcare provider when it comes to that. There are guidelines that are there, but as Katrina was saying, a lot of those have not really looked at this young age group. And so I will leave that right there. But I will point out that a large proportion of young women who are diagnosed found their own lump.
And going back to you, Katrina, what would you say is a young Black woman's best defense against breast cancer? Would it be this self-diagnosing that, to me, since they're finding that themselves a lot, or anything else that you could think of?
One of the major parts of my career has actually been helping women understand their risk of cancer. And so I think there's now lots of tools for people to start to ask about their risk, when they should begin screening. We talked about mammography screening. When should they think about self-examination? And so I think knowing your risk, knowing what your own risk is really important. And so one of those pieces for me has been helping women, both as I see them as a doctor, but also in the community and lots of groups, understand whether they're at risk, understand their family history. So get to know about their mothers, their sisters, their father's side, and use that information to decide about checking for lumps and getting screening. I think is by far the best approach to reducing that risk.
And so as a provider, I'm going to ask you the same question that I asked Tamika. How do you feel patients can better speak openly during their appointments, and what can doctors do to to enhance that?
Well, I've spent so much time trying to get to know patients who I think have had really bad experiences with doctors. We did a study a long time ago that back to this issue of trust. And it showed that actually, if you study trust, that most issues with trust come because people have been treated badly. It's not some some imaginary thing that exists. It's because people have experienced discrimination and racism and all the things that you talked about, ZOANNE. Like going through medical school, I think as an African-American woman, as a Black woman, must have been an incredible experience, what you felt and saw. And so I think those experiences mean that people come to doctor's appointments very wary. So for us, I think it's having the open conversations. I can't tell you how many patients I've talked to that said that they went to see their oncologist and they don't remember a thing that they said. They were just trying to get out of their room. So what I tell people, and this is like, it's bring a girlfriend, have somebody with you, get your support system if you're facing a cancer diagnosis, and bring it with you. And if you feel like you're being treated badly by that doctor or that system, you need to get out of that system. You need to find a place that's going to treat you the way that you deserve. And I've had patients move doctors, oncologists, so many times. And I think they deserve to do that, but they deserve to have the support when they come in to be seen too.
I've also heard of some advocacy groups that will help patients navigate through systems. I don't know how to resource those, but I know I've read about those, and those sound like really, really interesting ways to go for people who don't know the medical system and don't know medicine and all the words and all that kind of thing, to be able to have someone in their corner, kind of like a doula, a doula of healthcare. I'm just coined that term.
Well, I think when we think about the stories, we so often think about the patients, but you're exactly right, Jen, right? Like there's these incredible characters in our clinics who have the force of nature, who are helping women navigate these incredibly hard things. And often they've been working in the community, they're from the community, and they're committed to helping women through these journeys. I can't imagine where we'd be without them.
Mhm.
Well, speaking of patients and patient stories, we have an excellent resource for that in one Shantae Drakeford. Shantae, can you come on and tell us about your experience with being diagnosed with breast cancer as a young woman?
Yes. Hey everyone. Thank you for having me.
Hi, Shantae.
Hey. My name's Shantae. I'm from DC. I'm also a military spouse. I don't have any kids. I'm a farmer, a nurse practitioner by trade, but today I'm a patient. And I guess I'm like a living example of the topic today, young Black breast cancer, right? And not just like the representation of like early stage, like 0, 1, and 2, but like the latter stages of 3 and 4, which we know affects the young Black population the most. And I am currently living with, since 2015, stage 4 metastatic breast cancer. And that means that the breast cancer has spread, it has moved outside of my breast. And my lesions are currently in the spine, the lungs, hips and ribs, but it also can go to the liver and brain. So basically, what not a lot of people know and understand is that metastatic breast cancer is the one that actually that kills. And I tried my hardest to get detected early. I did everything, but I just wasn't listened to. This was my initial diagnosis. I was being denied and delayed the proper diagnostic test for 6 years, even though I'm a medical professional. And so you always have to ask that question, was it my race or was it my age? Either one of them were wrong, right? So I was diagnosed at 31, and I started actually having symptoms they was calling benign symptoms since I was 25 years old. It started with nipple discharge. It actually happened the day after my husband came from Iraq, because he serves in the military. And I went to go see someone immediately because I was a young nurse then, and I wasn't afraid to find out. And, we preach, early detection saves lives. So I was seen, I got an ultrasound. I was told I had dilated breast ducts. I had fibrocystic breasts, meaning I had a lot of cysts in my breast, dense breast tissue. And the nipple discharge was yellow at the time. And it was like, oh, that's normal. Don't worry about it. You're too young to get breast cancer. And then I was like, well, shouldn't I get a mammogram? And they're like, no, you're fine. You don't really need any intervention until, the discharge turns bloody. And me, I'm young. I'm like, okay, I guess, I didn't really have like the advocacy skills that I have now, which is why I speak a lot about it. It eventually turned bloody, and I had that breast duct removed. I had surgery, and I also had a cyst that grew really large, like 8 centimeters, but it was soft, right? It was a cyst. And technically, you could get that biopsied and drained. And when I went in to get my surgery, I asked them, could they drain that? Because it was uncomfortable. But because I didn't know informed consent, right? It wasn't on the paperwork for them to drain it, so they wasn't legally liable to do it. And so that cyst ended up turning into a hard rock lump like months later. And this whole time, basically, it took 6 years for me to get diagnosed. That whole time, I was asking for mammograms so many times, and they would just say, no, you're too young. We don't want to increase your risk of radiation, or, it's just a cyst, and, it's fine. You're okay. And I was just like, okay. So I was only able to get like ultrasounds for like every 6 months to a year. No one ever offered me high risk screening, or anything like that. So to be honest, like I come and I talk about Black breast cancer, and I got into advocacy and talking about it because I didn't see anyone that looked like me when I was diagnosed. If you look up anything, even till now, you don't see a lot of Black representation. And, in our community, sometimes we don't want to talk about it. We want to tell our business, and we need to be quiet. And I was like, no, I need to talk about it. And I need to, really make awareness about it. And it really wasn't until like 2019 that I actually saw someone that was another young Black woman with breast cancer. And now I think our advocacy has gotten so much stronger now. But the key is like metastatic breast cancer, because, we die 42% higher than our white counterparts. And triple negative breast cancer, which affects the young Black population the most aggressive, and in media, we see these things, but we also see someone gets diagnosed with cancer and then also later, dying, or like rather quickly. But there's life, there's survivorship in between that. And it's been 6 years since I've been diagnosed, right? And I'm just so blessed that I'm still here. So it's something that I need to do, I feel like, and an impact I need to have, and just talk about it,
So you say that you didn't have a risk assessment. Do you know what your risk factors are now? Like now that you've gone through, what type of risk factors did you have?
So when I was diagnosed, they did do a genetic test on me, and I did have 2 aunts who had breast cancer. One died. One was actually during her screening diagnosed like a month prior to me. And so when they did my genetic testing, I did not test for BRCA1 or BRCA2, but I did test for a genetic trait for colon cancer. And you guys mentioned colon cancer earlier, how it's affecting the Black community. So now I have to get cervical cancer screening and colonoscopies for colon cancer screening on top of living with stage 4 metastatic breast cancer.
And what is your day-to-day life like living as a patient with stage 4 metastatic breast cancer?
Yeah, it's unpredictable, and and that's another thing we don't always talk about. The living and the life of a metastatic breast cancer. We always just talk about the death, and we know that it will happen eventually. It's a terminal condition. I will be on treatment lifelong. I have to get treatment all the time. Treatments can vary from weekly to monthly. Right now I'm on monthly. And I get scans to make sure the cancer hasn't progressed or grown and spread any further every 3 months. Some days, although I don't look like cancer, right? There's this stigma of what cancer looks like, bald or really severely ill. And as you can see, I have my natural hair. I probably could pass. We come in all different sizes and capabilities. But although I look well, I don't always feel well. It takes me 30 minutes to do my dishes, like maybe 5 dishes. It takes me 30 minutes. I get winded. I get exhausted. I have cognitive impairment. Like I forget things quickly. Like I forget words, like just now, it can happen anytime. When I'm trying to clean my house, I can't. I have to get help. I may wake up in pain. I'm in pain every day, actually. It's just at a level of what's my tolerance level of pain, right? I may be nausea. I may have fatigue. But then there are days where I have all this energy, and I have a farm, and so I have chickens and ducks and things, and I can accomplish a lot of tasks, and my energy is on fire. I can
Is this
probably
in
work out
DC?
for an hour. Yeah.
Like chickens and ducks in DC?
You can have chickens and ducks in DC, but I live actually in Maryland, on the outskirts of Prince George's County, like
Okay.
15 minutes. But you can have it in DC too. But I have like 2 acres of land, and I might could be on fire, and then the next day I'm like, oh, I can't move, I can't get out of the bed, and but my mantra is just like, you got to enjoy your life and do what you can now until you can't, because there will be a moment where I can't. So I can't work as much like I used to be. I was a labor delivery nurse, and I was able to work 12-hour shifts, night shifts 3 times a week. That cut out. I can't do that anymore. I'm a primary care provider, so I work like once a week. And then like I wanted to do things that make me happy. Like although I have cancer in my hip, I begged my orthopedic oncologist to like let me snowboard. And he was like, no. And I was like, just please, just please. And he finally said yes, because like, who is he to get in my way of my quality of life, right? I laugh with my friends. I make uncomfortable, like, sarcastic jokes about my cancer, and I go to support groups that they're like my lifeline. To have someone to understand what you're going through day in, day out. Family and friends don't always get it, but they do, right? I travel. I like to have no cancer days. And I do a lot of advocacy because I like, it needs to be a lot of more research out here. And, the goal is for me to just keep doing this until I die, because I have to make change. There's a reason. But yeah, my life could be unpredictable at the end of the day.
Well, you mentioned advocacy, like, you're going out and you're being an advocate. As we talk about this next topic, let's go ahead and bring on Angela, who works on Mixed Dish. And I wanted to segue by asking you, how do you feel that representation from you and just in the entertainment industry matters? And so we'll start with Shantae and then move into Angela to answer.
Right. Like media and TV right now is like the most influential format that can create change and bring awareness. It's actually at its height of the movement right now. And, how do you get the viewer to think about this breast cancer, Black breast cancer in a creative way and bring it to the forefront? Sometimes like I've Googled like breast cancer patient, and majority of the images were older white women who are bald, right? And like, for example, I did like a speaking engagement on Capitol Hill with congressmen in support of the Early Act, right? And just telling my story of living life as a metastatic breast cancer, and it was televised. And, I went up there, said my speech, and then I look at the news and didn't mention metastatic breast cancer. It didn't show us, none of us, especially me. And at that time, I was the only Black person there. None of us were bald, but they zoomed right in the audience to a white person that's bald and called that representation. But they didn't say the words metastatic breast cancer, stage 4. It's like this scary word. We need to, sometimes you hear in the media, it's the more aggressive form, or, they died of complications of breast cancer. No, it's the metastatic breast cancer. And we need to help educate, the society that even if you have early stage breast cancer, 30% of the breast cancer, it could come back as metastatic. So we need to understand it. And since we're on treatment lifelong, we need the medicine, we need the money for the funding. And media is like great at that, and representation, clinical trials, understanding and breaking that narrative down, that it's not experimental. It's a revolutionary thing. It's history making.
And Angela, do you agree?
Oh,
Yes.
for me, Shantae, I just love you. When I think with the media, especially for breast cancer, when my mother caught breast cancer, she had triple negative breast cancer. The only images I knew were pink stuff, and we can all just take a walk and she shaves her head, maybe gets her breast taken off, and she'd be cured. Of course, she advanced to stage 4 metastatic breast cancer. But I think specifically with breast cancer, we need to do a lot better job. And I think, Shantae, this is what you said, of showing from diagnosis to the end, just how many different variables there are. I had never heard of dense breasts until my mom got breast cancer. Just so much I had to learn through watching my mom go through it, and had never saw it on TV.
Like,
so now, go ahead.
I was just gonna say, like, if folks don't see us, they can't relate. And if they can't relate, they ignore. And if they ignore, they die. So we die. So it's important.
Representation matters. So Angela, speaking of your mom, now that you have that history, are you now advocating for earlier mammograms for yourself, or what action are you taking because of that?
It's interesting, because I think most people on here are medical professionals. When you get inside a room and you don't know half the words they're saying, I automatically default to, okay, whatever you said. Even my mom, who was an RN, and I felt like Katrina could have been talking about her, she grew up and taught me when I was growing up, don't trust doctors. One of the first things I remember being young, my mom coming home upset because some of the white doctors were trying to trick a Black patient of hers into naming her kid umbilical. And so, I've grown up with this lifelong fear, even though she was an RN, of how they're going to treat me. So even myself am very intimidated, and I almost have to arm myself with a bunch of knowledge before I go into any appointment.
Wow. Have you guys touched on that at all on your show? Because I know you guys touch on a lot of topics around young Black women and healthcare. Is there anything that you've touched on as far as like distrust of the medical community, or?
Yes. We did an episode on Mixed-ish about fear of the flu shot, and the main Black woman in our show is trying to act like she got one, but didn't really get one. And what I like about that is that we're able to not only show, because I feel like too much in the media, it's just like Black people are afraid of doctors. No, it's a fool me once, fool me twice type situation, where it's like, my mother was alive when Henrietta Lack's cells were taken from her without her permission. It's we have been mistreated. There needs to be trust earned back. And so I think the fun part about doing it on TV is that we get to make people laugh, kind of hide the history in the middle, like hide peanut butter, like medicine around peanut butter for your dog. But also get people, but get people to understand where we're coming from, that we're not just these dumb people that don't appreciate science.
Yeah, I feel like that's a lot that's happening with the COVID vaccine too. As far as like, I have a friend whose mother is a nurse, and I asked her if she was getting the vaccine because all the healthcare providers were getting it, and she was like, "Yeah, she said she's just gonna wait and see how it goes, because Tuskegee." And Tuskegee. So how do you think that we can get more stories about the patient provider issues into mainstream TV?
Goes to the same thing we need in medicine. We need more representation inside of our rooms, because when I'm the only person of color sitting in the room and I bring up, well, maybe the woman has dense breasts, and everyone's like, never heard of it, doesn't exist. It's hard to fight 10 people on what is your reality if it's not their reality. So we need more of us in the rooms to do that.
Absolutely. And also, I'll just say to the people watching that accessing resources like HHS to prove your point in the room, because even as the physician in my room, I'm so war torn. People don't, you can't be a prophet in your own land, that whole kind of thing. Like, I can say stuff and I'll need like 4 experts to back me up to say, oh no, this is really real. Like, this is really what's happening, because they're just so used to me. And, that's just ZOANNE saying that. But then I get like 3 experts and it's like, okay, well, I guess she knew what she was talking about. So, accessing the experts and, through entertainment, I think you'd agree, Angela, we have like this, the world is our oyster, basically, because people want their issues expressed and they want these things. So in order to tell your story with authenticity, it's great to access people like Shantae who have had the stories, people like HHS who can get you to Shantae and get you to these wonderful doctors, so that we can tell our stories authentically? No, that's not a word. I almost said authentatious, which is really not a word. So you know what I'm talking about. So Angela, what would you say is that the attitude in Hollywood these days around telling more stories of Black people, particularly women? And do you feel like it's changed recently?
I think I've been writing for 20 years and I'm in the half-hour space, which is notoriously white and male. I think it's changed a bit, but it is still a fight. Whereas people don't realize, as writers, sometimes we're answering to advertisers and execs and people who don't want to see certain things. If they have a medical product that's in the show, we can't show anyone dying in the same. So there's a lot of moving parts. It's a bit better, but I say don't get into this if you're still not ready to fight to have some representation or to tell the stories you want to tell, because it's still going to be a fight.
Yeah, I think that what you said about, if you mention a product, you can't have people die. And there's just all these extra factors that are important. And like you said, and then the show has brands, like Grey's Anatomy has a brand. Like what I started with is just like, our doctors treat everyone fairly. So we're not going to be able to address these kinds of issues. But like New Amsterdam is all about like the county and the social problems and the this and the that. So they have a little more openness into talking about these things. But there has been a push for Hollywood to be more inclusive. Do you feel like that is a sincere push, or is it just like we're just saying it to fill some quotas or whatever it is? How do you feel about the state of Hollywood?
I feel like there's a sincere push to have more diversity in the room, but I'm not always sure that that diversity is listened to. Sometimes it's a pat on the back. I have a diverse room, but if you try to speak up or you go against the status quo, you're not really listened to. So again, I think it is a fight.
That's really interesting. Do you continue to be one of the only Black voices in the room, or have you noticed that it's changed?
Recently, yes, it has changed. I'm so happy. The younger kids coming up, and the younger kids also don't take a lot of guff. Yeah, they're super young. They're like 25. Like,
I've been writing as long as you've been alive.
Really, I really have. So and they also come in to me a bit more educated, and they're not going to get shut down as easily as people of my generation were. And I can't sometimes learn from them. I'm just like, yeah, go. Plus,
Yeah, I
can
feel
sit
like
back.
it's not even that they're more educated; they're just louder. Is it
Yeah.
Gen Z? Is that who it is? After the
Yes.
millennials?
Yes.
Like the millennials like brought up the problems, and then Gen Z is like,
Yes, because when we were coming up in a room, at least for me, I was taught your first year, you're supposed to just sit there and learn and don't say anything. Some people even had to raise their hand. These kids will come in and tell me I'm wrong. And I'm like, good for you.
yeah, sometimes. And sometimes I'm like, sit down.
Yeah.
All right. Okay, I do believe we're supposed to move on to the Q&A, or am I early? I don't know. I'm gonna ask some Q&A questions. One of them says, is there a better time in your cycle to examine the breast or get a mammogram?
So, hey, I'm happy to take that one. You want to give me that one, Zoanne, or not?
I'm gonna toss it to you.
Excellent. So, we do know in general that like the best time is probably early in the cycle. So right around the time that menses ends is probably the best time to do that. And so I think that is the bottom line, though. I guess I'll just get back to Shantae's story. I was listening to Shantae, right? Is that like these stories are also about, or what Angela's saying is about women fighting for their rights, right? Mm-hmm. Like women in these settings, Black women fighting to get heard. And so I think the timing of the mammogram might, but most of the stories that we're trying to get out there are about people trying to get the healthcare they deserve any time in their menstrual cycle. So it's really about yes, timing may matter, but I think the challenges are when people can't get the healthcare they need at other times.
Yeah, I wanted to add to that because it's a diagnostic issue, right? So the key is to label it as a diagnostic procedure instead of like a screening format, and it will be covered better with the insurance, but although the standard diagnostics are like to start with an ultrasound, ultrasounds are not that great. And even with the mammograms, unless it's like a higher like a resolution type mammogram, they may not even get it because the young Black women have dense tissue. I think MRI should honestly be the first go-to, but we have to fight with the insurance and the coverage, and that could be a hindrance, and that could lead to later diagnostics of being staged later and things like that as well.
Shantae, are you on daily chemo? Like, do you take?
Yeah. So the key with stage 4 metastatic breast cancer is quality of life. And I know standard treatment is to go with IV chemo and mastectomy and, the radiation. With me, since this was my initial diagnosis and approach, it was a little bit different. And my doctor said it's like a marathon, not like a quick race. And so I only have so many medications in my bag because there are not a lot of treatment options, especially for triple negative patients. I'm triple positive, meaning the cancer grows off of estrogen, progesterone, and the HER2 receptor. So I have a little bit more options than most. But ultimately, I stay on this regimen until it doesn't work anymore. And then that's done. And then I move into the next one and next one until basically I die, because I'm keeping everything at bay. So right now I'm on my first line, which is a blessing that I've been on my first line for like 5-6 years almost. And where some people can go through their medication in 3 months and a year. And then, so you're going through these medicines really quickly, your likelihood of survival lessens and lessens. And so I take oral chemo drugs, which is not always covered by insurance because they don't see it as the same quality. It's the same thing, and it is. Not all chemo is IV done, and I'm in medical menopause, so you could have an option of getting a hysterectomy, taking your ovaries out, but I got the option of getting the injections every month to shut down my ovaries, so I get the high flashes and the weight gain and all the side effects of menopause. And I had radiation into my hip. I was on crutches for about 5 months because the tumor on my hip is so large. And I take, of course, all the pain medications, but mainly it's hormonal therapy because the tumors grow 95% of our hormones. And what I think triggered it to just grow very rampant, I had IVF the year prior to diagnosis. And all that hormone pumping, I think it contributed to, of course, they're not going to say that causes it. And we don't really know for sure that causes it. But I think it had something to do with it. I probably already had the cells there when I was having symptoms at 25. But the IVF and the IUI just kind of like, boom, made it grow quick.
Well, yeah, if it's responsive to estrogen, would seem,
Yeah.
it seemed kind of. Angela, did you see the same kind of thing with your mom as far as like her going through it, as far as like having to ask harder for pain control and just having to speak up a little bit louder than what seems necessary?
I saw a bit of that, but I also saw the pressure on her because it's a racism rears its head again, but not wanting to be seen as a lazy person or that she's seeking pain medication. So she was hesitant to take too much. She still wanted to go into work every day when it's clear she couldn't, because she was afraid of how people were going to stereotype her.
I deal with that all the time. The guilt, right? It's like, I have to get disability for income because I can't work anymore, right? Like that. And I was like, I'm not disabled, I could do it, but I really can't. And then you just feel like I could do it, but you really can't. And my palliative care doctor, which I always recommend everyone to go to, even because we think of palliative care like end of life, you're gonna die, but it's about quality of life, right? And I think everyone should have that. My doctor told me, why are you going to sit here and live and suffer? Don't be afraid to take the pain medications. I do homeopathic other things too. I do chiropractic, massage, all those things, but I need it all, right? And I just think that, my provider helped me, my palliative care doctor helped me with that because it really truly is about quality of life.
Yeah, I think the palliative care and the support group that you talked about are two big major lifelines that people don't access and that are super, super duper important. And just on my personal level, it has nothing to do with breast cancer, but with COVID and Alzheimer's, because my mom had both of those. And through my mom's COVID stay, I, contacted palliative care and had a whole team of people who were helping me to decide next steps with her, considering she had Alzheimer's and all of that stuff. And it was just so, being an only child, it was just so great to just have people to talk to and all that kind of stuff. And then I have a support group for, kids of Alzheimer's, and that has been like a lifeline. So I know that doesn't have anything to do with breast cancer, and I just talked about myself because that's what I do in the writer's room. And that's how we got episode 5 of this season. Because I always, if any of my writers are listening, they'll be like, "Oh, she's missing her mother again." It's been a whole thing every day. But let's go to some Q&A questions. It says, "Hiya," from Suzette. A book I read, this is from Suzette, mentioned that you should have clinical breast exams along with yearly mammograms. Then it goes on to say 76% of primary care doctors don't do clinical breast exams, and to make sure that they can check the axillary and supraclavicular areas. Can you address this? And why aren't all primary care doctors able to do this? And what are these areas? And can we check them ourselves? There's a lot of questions in there for you. Probably for Doctors Armstrongs and Fairley, I would say.
Mika, you want to start and I'll go second on this one?
No, you can go first and then I'll go second.
So I will say, we're back to that issue of whether or not, I don't know, I mean, maybe I shouldn't ask you guys whether you check your own breasts, but I check my breasts. I think most women decide to get to know their bodies and to make sure that they don't have lumps. And I think that's something, as Tamika said, that we don't have large randomized trials to show that it's necessarily going to work, but we do know that women find lumps, and we do know that taking care of your health matters. So I think it's something that we do. Because there aren't guidelines that say it works, most primary care doctors don't aren't, what they really should do is ask the woman, right? Because if a woman wants somebody to check their breast, that makes a ton of sense. If the woman doesn't, you don't really want a primary care provider doing something that it hasn't been proven to work, right? Like there could be all sorts of bad stuff there, I would think of, that we don't want to get into. So my guess is for why they're writing or asking the question is that we don't have it in our guidelines right now to the level that shows it's going to save lives. I would call it more in the, patient-driven side of healthcare. So do you want me to do, Zoanne, your doc? Do you want to talk about where the supraclavicular part is? I could probably. So axillary, you guys, is up in your armpit, right? So that's what axillary means. Yeah, Joe, I knew we got somebody who showed. And supraclavicular is right here, just so you guys know.
Above your
and so
collarbone.
You like that? That's my, yeah, above your collarbone. Exactly. I think that's your clavicle, right? So that's where people think. I'm actually not sure the supraclavicular is really very common with breast cancer. It's more seen if you get a lump there from other things, but axillary is definitely a part of the exam when we check for lumps for breast cancer or in that way.
I always mention feel on yourself everywhere and know yourself regularly, because that's how you're able to identify change quickly, because you know your body best. And then when you're young, you're not really, honestly, let's be for real, like when you're young, you're not really thinking about touching your breast, and it's not on your forefront. And so we have to try to help increase that and make it normal, because when I was 25, I mean, I did it because I was a healthcare professional, but if I wasn't, everything that's on your mind when you're 25 is planning for kids and your future careers and having fun. And cancer does not cross your mind. And a lot of my patients, they're like, oh, I need to do it. Oh yes, let me teach you. And this is why. And you feel anything, you come to me, I will get you something. You know what I mean? And so we need, I guess just to have that understanding and just talk about it, even at teenagers to your young kids.
And I also think it's important that we make sure that women know, that there are other symptoms, right? So it may not always be a lump. It could be a rash. As Shantae mentioned, it could be, discharge from the nipple. There are other things. And so knowing what the symptoms are, I think is something that we want to make sure that, in particular, young women actually know what those are, what it looks like. Because if you don't know what the symptoms are, even if you kind of know what's going on, I know I'm giving visuals over here. Y'all can't see that, but
she's doing her own breast exam over there. Don't worry about her.
Right, exactly. But knowing what's not normal for you for sure. But even the very specifics of then what's not normal, what kind of rash isn't normal, right? What kinds you need to get looked at, what kind of changes in your nipples are not normal for you, and being aware of that is really, really, really important, because then going to see someone and possibly having to fight hard, unfortunately, to get seen as something, you may feel a little more empowered to do just because something's going on.
Yeah, it reminds me of the two breast cancer stories that stand out from Grey's Anatomy for me are one that we just did with Maggie's mom, just a few years ago, where it started off with just a rash, and it was inflammatory breast cancer.
Yeah.
And then way early on, maybe second or third season, we did one where a woman thought, she had some lumps because she had just had a baby. And so she put it off. And then by the time she got there, she had more progressive disease. So yeah, just having to look for changes, look for differences, and don't ignore them, and make sure that you are heard when you do go talk about them, go get them seen about. All right, so Therese, I hope I'm saying that right, is asking, what about the socioeconomic impact of diagnosis and treatment? There are Black women who don't have proper access for either. How do we advocate for that portion of our community?
Oh yeah, that's a big one. because, I always say zip code matters. Even for me, who is considered like a middle class woman, I live in like one of the wealthiest counties, heavily Black populated, but still can't get cleaning services for myself, meal support services. It's barely any rides, or if it is something, it's only one or two, but 30 minutes down the road is a higher access component, and they have everything, all the services, or I'm having to really go out and drive, but everyone don't have the capability to drive. Some people are catching public transportation, and we know most of the cities and the inner cities are the ones who are mostly affected by the breast cancer. And so how do we ratify that? We need mobile units to go into the community. We need people coming to the community, like providers, instead of us having to go to the institution. And you notice all the institutions are in a heavily populated Black community, but yet they can't get the Black population to be in clinical trials or get proper treatment or prevent us from dying. At least that's the excuse, right? But I just think we need to be creative. And then, like I think someone mentioned, having that person that will advocate for you and be your back. Like, no, I need help with this. I need a social worker, a nurse navigator,
Right.
And so I think that can help the communities who don't have all the access.
Yeah, I think this is one of those areas where education through media, through TV and what have you, is really has an opportunity to make a big impact. And one of the things, as Shantae was saying, we normally see when we do see the stories, it's like they were diagnosed and then you rush through to the end, so you see the beginning and the end. But people have lives that they're living across this time. And some parts of that life may be struggles with getting, access to care because of these, because you don't live in the right zip code, or because you have a different kind of insurance, or because somebody perceives something differently about you. And I was talking to some of my colleagues, and we really talked about how possible is it to have subplots, or having some of these things woven into people's stories, because there are real things happening under there. Shantae's a nurse and having this real life in practice, and raising chickens, and she's doing all of these things, and I don't know that it has to be out front always so overtly, but it is happening, and people are trying to live their lives, but if they can't get, what they need to do that, that's a problem. But things that aren't seen don't often get addressed.
Yeah, that's definitely something that we wanted to address on Grays, because again, how representation matters. One of the writers in our room lives with metastatic cancer, basically, just like you, Shantae. And she's raising a family. She just got married and has 5 stepkids now. She had none before. She's living a life, and we really wanted to show that on our show, that there, you can have what seems to be aggressive cancers, get through it, be on your daily chemo, get your MRIs and CTs and screening and on all of that. I guess it's not called screening once you actually have it. But we don't like, it's not her everyday struggle, but every once in a while we'll say, oh, my scans were negative. This is wild how this is going. So it's a character that's living with cancer, and she happens to also be a Black woman. So she also happens to be Debbie Allen. So it's very impactful, I think, for television when there are people that are characters that people really relate to and understand, and therefore it doesn't seem other than, it feels like, your friends and family, they're going through it, and how can this impact me, and taking in the lessons, or not the lessons, we're not teaching lessons, but taking in the information and applying it to themselves and getting themselves out there to be seen, and that sort of thing. And I am going to wrap
Joanne, can I just jump in for 1 minute on that socioeconomic thing? Because I just dealt with this week as you wrap up. Because I think one of the things that the stories don't get out is how many times people aren't actually even able to cover their medicines. And so what they end up doing is instead of taking them every day like they're supposed to, they stretch them out. Because they're either picking between, the medicine or rent or whatever's going on. And I don't think there's awareness that so many people facing cancer right now could do so much better if we had ways that they could just cover their medicines. And I think there's such an opportunity there.
And ZOANNE, there are some advocacy organizations that are supporting some of this, and probably would definitely have their own stories to talk about. So organizations like Patient Advocate Foundation, Tiger Lilies. There are those organizations that are engaged in trying to help people get that kind of access, to get their medications, to get to and from appointments. Like, no one really talks about how big a deal that is, but for some women, it is huge just to get from where you live to an appointment, to get off work and not lose your job and then get to appointments. That kind of support is huge.
Like to have after hours.
Yes.
And to be more accommodating to people who do have jobs where they feel like they will be fired. And do you have to choose between your job and your health? Is not a great decision to have to make.
Childcare coverage. Yeah.
Yeah. Childcare.
I got a list of the organizations. I can list them all. You want me to say them?
We could do put a little extra thing on here on the
drop
tag.
It in the chat.
I'll drop
it in the chat is what we always say in the room. So this is, I think, a question for everyone to address. And I guess we can go in order of your appearance on the panel. What is the one message that you feel is most important to get out to help educate the public about healthcare disparities and or breast cancer? Tamika.
It's actually a really great question. Let me see if I can narrow it down, to people in the community. I would say, you deserve great care. You deserve excellent care. And it's not wrong or a bad thing to ask for that, advocate for that, push for that. But I was about to say by whatever means necessary, but I don't think I can say that on behalf of CDC. So, but the support that you need to gather, the whatever it is, you deserve great care. And at every level, we're talking about it for breast cancer now, but this is what you deserve, right? As a human, as a person on this earth, you deserve that. And we're talking about how to get to some of that. But I think knowing that in your minds, as things come up, you deserve it.
So, I guess if I was going to give one message, and I've been thinking about this a lot if we've kind of come out of COVID here, right, is that these disparities are not somehow written in stone. Like, these aren't biology. These are things we created. And if we created them, we can fix them. And we turned this country upside down to healthcare upside down to address COVID, right? I mean, look at what we did. We got vaccines in record time. We're going to get them out. And so we should be doing, we don't need a moon. We need to fix this. And we created it and we should fix it.
Beautiful. Shantae.
Yeah, my mission is I'm trying to just save people. And I know one day I would die from this and no one knows when. But just like our ancestors who fought for us to be where we are today, I'm fighting for the greater tomorrow to stop us Black women and men from dying. It has to change, at the end of the day.
And Angela, I don't know if you remember the question, but
I'm just going to piggyback on what Tamika said. I think educating people not only that they deserve good health care, but what exactly good health care looks like. And if I can sneak a second one in, perhaps educating people in medicine about some of the disparities that are kind of baked into our system so that they'll better know when they're acting like that.
You can't sneak a second one in.
I was going to try to stick one in too, but okay.
Okay, fine.
Okay.
You pulled my arm.
Well, just to piggyback on Angela's, you know, a lot of people don't know when their biases are leading, and so I think in the clinical area, you start to teach that earlier than later, right? And so helping people recognize, like, even when things are biases, and when you become the powerful person as the provider, then you have the risk of it becoming racism. That bias that you bring to it, combined with the power that you have over the patient, that moves you into the discussion of racism, and keep that in your minds.
I love that bias plus power equals racism. I mean, that's just the simple like addition that I've ever seen for it. Yes. And I think that, you know, in entertainment, Angela and I and our colleagues can promote all of this, just like having our doctors recognize their bias and having the patients pointed out, just like having that be part of the conversation and talking about it, because I think not talking about it and being colorblind can sometimes just make it go on forever. So bringing it out, talking about it, discussing it, I think us bringing it into your homes can help that conversation start more easily. I know a lot of people watch our show with their kids and then have hard conversations after it because of what was on the show. So just fostering that and keeping that going through generations, I think can be an amazing way to merge entertainment and this public health crisis. So we're going to turn it over to Kate Fulb. And thank you so much, ladies, for an incredibly interesting panel. And you guys are so lovely and educated and knowledgeable. I cannot even get over myself for the luck I have in meeting you all. Except Kate is nowhere to be found. So we'll just talk until, oh, there she
is.
I wasn't sure if I had to do it or if Leica was going to do it, but there we go. Thank you, everybody. This was a fantastic panel, so informative and just and funny and entertaining and fabulous. And so thank you all. Thank you, ZOANNE, for moderating such a great panel, and thank you to all of our panelists for being here. Those of you in the audience, before you log off, there'll be a survey that pops up to ask you how you felt about this panel, and we'd love it if you fill it out. And if you don't have time to do it now, you'll get it in an email tomorrow. So we're not going to let you escape without giving us your opinions. And then also just quickly, I wanted to remind everyone that on March 25th, Thursday, March 25th, same time, 4 p.m., we're doing another panel on it's called Money Matters, Changing the Story of Poverty, Prosperity, and Opportunity in Entertainment. So please join us for that. It's going to be a fantastic panel. We've done some great research recently on how poverty is depicted in television and film and what needs to change in that regard. And we have a great panel with Stephen Canals from Pose and the Linda Chavez and Marvin Lemus from Hentified and Anthony Sparks from Queen Sugar and Erica Green Swafford from New Amsterdam. So we've got a great lineup for that one. So please join us for that. Thanks again to all of our panelists, and thanks to the audience for being here. And don't forget to reach out to Hollywood Health and Society with your questions and concerns, either about this topic or others. Have a good evening, everybody.